Thank you, Dr. Milavitana and Professor Matthias, for guiding us through the symposium. Up next is a rapid-fire session on various critical updates in infectious diseases. This will be chaired by Dr. Prabhashini Kumarihami, Consultant Physician at Teaching Hospital Kurunagala, Senior Lecturer at Department of Medicine, Vyama University of Sri Lanka, along with Dr. Dinushka Jayavira Bandara, Consultant Physician at Teaching Hospital Karapitia. I cordially invite Dr. Kumarihami and Dr. Jayavira Bandara to conduct the session. Thank you.
Good evening, ladies and gentlemen. Welcome to the final segment for today's program. So it's going to be a rapid fire session, and it's going to be on updates in infectious diseases. So without further ado, let me invite the first speaker, Dr. Niranjan Dissanayake, who's a consultant respiratory physician, and he's going to talk to us about Mycobacterium avium complex. Over to you, Dr. Niranjan.
Thank you very much, Dinushka. So without much ado, we'll start the discussion. It's an update on NTM together with a special emphasis on Mycobacterium avium complex. So with the first X-ray that is there, I think we can identify the first conundrum when we face the non-tuberculous mycobacteria. So onto your right, onto your left actually, you will see the fibrocavitary type of Mycobacterium avium complex. And into the left, you will see the nodular pancreatitic type of non-tuberculous mycobacterial infection. And the first thing comes to our mind is tuberculosis. So one important aspect about non-tuberculous mycobacterial infection, especially Mycobacterium avium complex, is that it can mimic tuberculosis, especially in a context of high burden or moderate burden countries like ours. It's a very important thing that we have to think about. Now, it can coexist with tuberculosis, and it can actually be a sequelae of tuberculosis. And sometimes it can cause diagnostic dilemmas. And this is a 66-year-old lady who presented to Kaluthara with 2 episodes of bacteriologically proven tuberculosis in 2019 and 2022, started treatment with anti-tuberculosis treatment, again presenting with similar symptoms, with this chest X-ray with a fibrocavitary lung disease, and acid-fast bacilli being positive. Culture was positive for Mycobacterium tuberculosis other than tuberculosis, and the patient revealed, as you see in the whole genome sequencing, Mycobacterium intracellular subspecies yongenense. So MAC is here in Sri Lanka, which we have proven about 14 years back when I was a senior registrar in Kandy, which was published at the ERS. And there we did some studies using bronchoalveolar lavage, where out of about 120 samples, 40 yielded non-tuberculous mycobacterial cultures, out of which some of them were rapid growth and significant proportions were slow growth as well. And species analysis has shown that there we have a mixture of non-tuberculous mycobacteria in the Sri Lankan context. Some of them might be pathogenic, but some of them might not. So I didn't go to USA or Japan, which are having a low tuberculosis burden, but when you look at other countries, especially China and India, with the highest burden, sometimes there might be a difference of the prevalence of these certain mycobacterial species. Intracellular seems to be commoner in China, but in India, fortitutum seems to be commoner, and I would like my Indian colleagues to comment on that as well. So when you look at the mycobacterium, non-tuberculous mycobacteria, just for a beginning, the most important thing is we remove the Mycobacterium leprae as well as the Mycobacterium tuberculosis complex, and then we are left with non-tuberculous mycobacteria, and all 3 have this unique cell wall which keeps the stain. Instead of being acid and alcohol, we can't remove it from acid and alcohol. And one of the most important things is tuberculosis, as you know, is transmitted from person to person, but non-tuberculosis mycobacteria is not. So hence, there are other factors that come into play. mainly the environmental factors. In Sri Lankan context, I think the soil reservoir is a very important thing, dry soil. And the second thing is exposure, especially the gardening. And the host factors, when we look at thoracic skeletal abnormalities, low BMI, as well as structural lung diseases, which are rampant in our population, makes a perfect person to develop nontuberculous mycobacteria, together with probably GORD, common variable immune deficiency, interleukin 12 and interferon gamma deficiency as well. So out of the 200 species, we are just concentrating on certain groups. Why? Because some of these nontuberculous mycobacteria are non-pathogenic. Even if they isolate from a person, we don't consider it as pathogenic and it is not significant. But when we isolate a type of organism that is to your right, then it is almost pathogenic. So there's a spectrum of nontuberculous mycobacteria diseases, and Mycobacterium avium complex sits at the middle. Hence, we are at a conundrum whether to start treatment or not. And Mycobacterium avium complex, even though we earlier identified avium intracellulare and Mycobacterium avium intracellulare, but avium complex has at least about 12 species which are responsible for the disease, and some of these subspecies are different from each other, and some of them have different responses to treatment as well. So when we diagnose, what is the criteria for diagnosis? The important thing is the bacteriological diagnosis. We have to confirm 2 sputum samples by culture to say that this mycobacteria is significant, because mycobacteria is there in the environment. Hence, a single sample might not say that you are having a disease, and more than 2 sputum cultures should be positive. 2 or more than sputum culture should be positive. That's the first one. The second thing is, you have, in the correct clinical and the radiographic context, there should be a bronchoalveolar lavage which is positive, or a biopsy showing granulomata or AFP with a positivity of a culture in sputum or bile is taken as diagnostic of having Mycobacterium avium complex. And then you come into the radiographs. You can see in the upper section the typical Lady-Williams syndrome. Lady-Windermere syndrome in the Oscar Wilde's Lady-Windermere's fan, where you can have lingular as well as right middle lobe bronchiectasis with some nodularity and tree in bud appearances. A typical patient will be a tall pectus excavatum patient who is having a lady actually with thin demeanor. And then you have the cavitatory type, fibrocavitatory type, which will be a tall, thin male with emphysema and who has been a smoker. So these are the characteristic radiographic findings. And then we have this clinical symptoms with cough, fatigue, and weight loss. And sometimes these changes might be very subtle, like in this patient where you had bronchiectasis with some nodularity. So the diagnostic criteria I have already told, and whether to treat or not, especially with regards to Mycobacterium avium complex, will be depending on whether the patient has risk factors for progression or not, and sometimes the patient's priorities as well. So the important thing is, even though guidelines says that any patient who fits the diagnostic criteria with Mycobacterium avium complex should be ideally treated, but I would like to share this slide because about 23% have been stable at about 6 years, even though they fitted the criteria, diagnostic criteria, and out of which about 50%, that is 1 out of almost 100, 10 out of 100, have actually self-converted into complete remission. So whether to treat or not is a question that we ask, because there is toxicity and it is a long-term treatment that we give. So the factors associated with progression are male sex, lower BMI, and younger age. Radiographic characteristic is the cavitatory disease, which tells us that there's a huge disease burden, and more than 4 lobes are involved, especially in a bronchiectatic patient, especially when you have systemic features like anemia, hyperalbuminemia, and elevated markers, especially microbiological findings like positive AFB is taken as a risk for progression. And other than the positive AFB, especially in the colony count, especially if we have a culture that is semi-quantitative and shows 1 + 2 + 3 + 4 after treatment, if the culture semi-quantification doesn't go down, then again it has a high risk of being non-converted. So the backbone of treatment is macrolides, that is azithromycin, which can be combined with ethambutol. Ethambutol is one of the market protectors of azithromycin or macrolides, because if it is azithromycin or macrolide resistant, the treatment outcomes are very poor and the treatment is very complicated. We have fluoroquinolones, oxazolinones, and as well as aminoglycoside, which is IV or nebulized for treatment options. And how would you treat nodular bronchiectatic? Basically, number of drugs are 3, azithromycin, rifampicin, and ethambutol, 3 times weekly. And cavitatory, we can use IV amikacin added to that as well on a daily basis. But amikacin can be given in a weekly basis. And we have to continue treatment up to 12 months beyond culture conversion. And in summary, if it is macrolide sensitive, that's the most important thing. If cavities are not present, weekly dose. If cavities are present, daily dose. And if the patient is having macrolide resistance, we have to go for second-line drugs and sometimes add amikacin as well, especially in refractory patients where if we have a 6 months positivity after guideline-based treatment, sometimes we have to give 4 or more drugs as treatment. It's not only drugs, it's rehabilitation, pulmonary rehabilitation, good nutrition, as well as avoiding exposure with nebulization with hypertonic saline and positive expiratory pressure will help. And surgery sometimes helps to debulk, and especially in treatment refractory patients. And even though if you give the correct treatment, you can see that the culture conversion rate in macrolide susceptibility is 80%, but there is a recurrence rate about 50%, and sometimes they are reinfected if they are living in the same environment again and again. And this is one of the new outcomes during the last 1 or 2 years, where you can have ALICE, that is not the next door ALICE, but the amikacin liposomal inhaled solution, which has shown significantly to reduce, especially in refractory non-tubercular Mycobacterium avium complex, the recurrence rates and treatment outcomes. We are awaiting this, there is a ARISE study which has combined 2 drugs, basically azithromycin and ethambutol together with ALICE, which has shown more benefit than giving 2 drugs alone, and we are awaiting the ENCORE study results, and there is now development in macrophage therapy as well, phage therapy as well. So when you're dealing with non-tuberculous mycobacteria, it's difficult to diagnose, but having a high clinical suspicion in the correct context, ordering cultures, trying to identify the species and if possible subspecies, getting a colony count and looking at the resistant patterns and starting treatment in an appropriate way in the appropriate patient, where we cure the disease rather than giving another disease to the patients without treatment. Thank you very much.
Thank you, Dr. Naranjan Dissanayake, for short but comprehensive update. So our next speaker is Dr. Lakmal Fonseca, who is a senior lecturer and is a specialist in internal medicine. He'll talk about the neutropenic sepsis. Over to you, Dr. Lakmal.
Thank you very much. My topic today is talking about neutropenic sepsis. Without further ado, let's talk about the terms, definitions, febrile neutropenia, and what is neutropenic sepsis. So when there's oral temperature more than 38.3 degrees and in 2 consecutive readings for more than 2 hours, and you find an absolute neutrophil count of less than 500, or whether you expect it to fall within the next 48 hours, you think that the patient is having a febrile neutropenia. So agranulocytosis is another term that is important. It denotes a severe form of neutropenia when the absolute neutrophil count is less than 100. And neutropenic sepsis means the above febrile neutropenia correlated with clinical severity, including organ dysfunction. If I talk about some statistics, it is the most frequent and most serious complication of cancer chemotherapy. So the problem is when you have neutropenic sepsis, you might have to de-escalate the cancer chemotherapy. It will reduce the efficacy and it will give a delay in the cancer treatment, which is a huge downside for the patients. And the most standard dose chemotherapy regimes causes 6 to 8 days of neutropenia, most of the regimes. And there's a considerable mortality, 20 to 30% of morbidity, and also a 10% mortality. When it comes to gram-negative bacteremias, the mortality is higher, around 18%. And when it comes to gram-positive bacteremias, it's around 5%. what are the current trends at the moment? So over the last few decades, there's a shift occurred from gram-negative bacteria causing neutropenic sepsis for more gram-positive bacteria. And they're also, in the face of growing AMR, more ESBL and MRSA and VRE and fluconazole-resistant Candida strains such as Candida glabrata are coming up more. And we are facing problems in managing patients with neutropenic sepsis due to AMR. So we need to identify who is at high risk. So we need to know about something about the chemotherapeutic regimes, because there are high-risk regimes, intermediate and low-risk regimes causing neutropenia, and also the clinical phenotype of the patient. If they are older, having advanced disease, if there's higher history of prior neutropenia, comorbidities, poor performance status, and importantly, if the patient has been on antibiotic prophylaxis with fluconazole or any ciprofloxacin, that kind of antibiotics, and also evidence of mucositis. So this denotes whether the patient at high risk or not. Also, it's important to know what are the high-risk chemotherapeutic regimes. So some cancers and some regimes are more prone to cause a very severe, profound neutropenia. So I have listed a few, especially breast cancer, lung cancer, stomach cancers, mainly lymphomas and leukemias. These regimes causes profound neutropenia. So once you get a patient on these regimes, do not have any delay in starting your broadest cover to save the patient's life. So what is the initial assessment? It is important to take the good history, knowing the nature of the chemotherapy regimes, because to classify whether it's a high-risk regime, intermediate or low-risk, whether the patient has been on prior antibiotics, which will help you to get your right antibiotic on board, whether the patient has been on steroids, which might pose you more fungal infections, PCP, and recent surgical interventions, or past records of positive microbiology. And also, examination is vital. Sometimes the infection might be very subtle and can be hidden. And evidence of mucositis is an important thing, because when the mucosa is, the barrier is compromised, it can easily translocate some oral bacteria into the bloodstream. And also look for a potential focus through your examination, and look for any organ dysfunction, respiratory or hemodynamic. Also look carefully at hidden sites of infection. They may be having a very subtle diarrhea, maybe having abdominal pelvic sepsis, perianal cellulitis, or abscesses or dental abscesses, which we might miss. So carefully in your examination, look at these findings, because of neutropenia, neutrophils are the main fighters of immune system. But if you don't have inflammation, you won't have signs noticeable. Looking at investigations, we can do a full blood count with absolute neutrophil counts, and important blood culture, especially from peripheral blood and also from the peripheral lines. And you can compare these findings to find out whether there's a line infection or a potential other site of focus. And also look at advanced modalities, because the inflammation or the infection might not be very visible. Go for CT, bronchoscopy, and also you can do outcome risk assessment by using the MASCC index. And through this index, you can identify whether you want to give an outpatient treatment or an inpatient treatment in these patients. So how you decide on outpatient treatment? You can do outpatient treatment in selected cohort of low-risk febrile neutropenic patients. If there's a low risk on this MASCC score, and hemodynamic is stable, no acute leukemia, no organ dysfunction, no invalid catheters, and if the patient can be reliably reviewed in about 48 to 72 hours, you can do oral therapy. Cormoxiclav and ciprofloxacin, a higher dose, mind you, with 750 milligrams BD covering the Pseudomonas, or sometimes moxifloxacin is used, but mind you, moxifloxacin does not have a good Pseudomonas cover, and patient review is important in about 48 to 72 hours, but it's important to avoid the ciprofloxacin or any group of antibiotics if the patient has been on prophylaxis before with those agents. Regarding the inpatient management, you have to give IV broad-spectrum antibiotic, looking at local susceptibility patterns as well. So piperacillin tazobactam is the main way forward when starting early within 1 hour, and you can couple that with gentamicin in our setting because we have a high burden of ESBLs. And if there's a minor allergy, you can use ceftazidime, but mind you, ceftazidime does not have a good cover for streptococci at times, so you have to be very careful on that. And so then you think about the site of infection. And because of the site of infection, you can further refine your antibiotic choice. If you think respiratory pneumonia, you can start adding azithromycin. If you're thinking Legionella, good intracellular penetration with azithromycin, levofloxacin. And if the patient has been on steroids, you can think of pneumocystic jirovecii infection and start on chlorotrimmoxazole. And if the patient has been prolonged neutropenic, having lung infiltrates, early initiation is mold-active antifungal agent is important, because you must not miss aspergillosis. These are very difficult to diagnose. Go for CT, galactomannan, and bronchoscopy, and think about starting appropriate therapy in liaising with the mycologist. And also, if you think of urinary source, think about switching to meropenem, because we have a higher incidence of ESBLs. And if the patient has hypertension, a catheter, or a severe cellulitis, think about adding an MRSA cover. And if you suspect meningitis, maybe best to give IV ceftazidime high dose, which has a good CNS penetration. Might be piperazine, tazobactam. Also, piperazine crosses the CNS well. The tazobactam does not have a good penetration, so it might not have good activity when they are beta-lactamase producing organisms, or meropenem can be used. Necrotizing mucositis, periodontitis, perianal cellulitis, neutropenic enterocolitis, these can be missed very easily, mind you. So you have to look carefully to those, and you can add metronidazole, but unless you have put on piperazine, tazobactam, or meropenem, they also have a good anaerobic cover. And if you suspect viral infections, add acyclovir and look for invasive CMV disease, in which case you might have to switch to ganciclovir after investigation further. If there's ongoing diarrhea, think about Clostridium difficile diarrhea. And also another thing that we might miss is if you suspect a disseminated candidiasis. With prolonged neutropenia and hematologic malignancy, especially myeloablative therapy, and especially if the fever does not respond with more broad spectrum antibiotics after 3 to 7 days, think about disseminated candidiasis as well, and do a CT. They have the specific microabscess formation in the kidney, liver, and the spleen. That might be a clue, and do further investigations to start on treatment. And a bit about device-related infections. There are 3 types of infections that you come across. Local infection at the exit site. Sometimes you can get the whole tunnel of the line infected, and there can be pocket infections where it is not communicated with the exit. And also, there can be device-related bacteremia. So the removal of the line is indicated when there's tunnel infection, pocket infection, or when there's persistent bacteremia despite adequate therapy. And also, if you suspect a mycobacterial infection or candidemia, there's a case that you might have to remove the line for better source control. And a bit more about the device-related bacteremia, you have to demonstrate that the organism is present in the peripheral blood and also the blood culture coming from the line. So there should be an identical organism. And also there's a thing called differential time to positivity. So both blood cultures become flat within 2 hours, which will there's a high chance that is a line infection, and usually if the blood culture from the line has a higher colony count when it comes to the culture. So what about further? The mean time of deferences is about 2 days in low-risk patients and 5 days in about high-risk patients. And if the patient is clinically stable, you can stop the dual therapy and stop the aminoglycosides and continue the piperazine or the meropenem. Or when there's causes found, you can give the specific therapy. And if the patient is still febrile after 48 hours and clinically stable, you can continue the initial antibacterial therapy. But if the patient is unstable, you have to escalate to meropenem and glycopeptide. And think about supportive treatment. Think about using GM-CSF quite early, and managing mucositis is important. And a bit about the duration of the therapy. If the absolute neutrophil count is more than 500, the patient is asymptomatic, afebrile for 48 hours, and cultures are negative, you can actually switch to oral antibiotic therapy or discontinue it. But mind you, oral gastrointestinal mucoside is a barrier to start on oral treatment because the absorption might not be good. But if still the neutropenia is persistent, but no complications, the patient is afebrile, you can continue basically 7 days. But if the patient is having a high-risk acute leukemia, have given high-dose regimes, then continue up to 10 days in completion or until the neutropenia improve more than 500. But if there's an antifungal regime that you might have started, you might have to continue it more until the neutropenia recovered or to nearing 14 days. Thank you. So, summarizing, neutropenic sepsis is has a high degree of mortality and morbidity. Getting the source to the source and giving broad spectrum therapy and optimizing your antibiotic therapy according to the source is vital for the patient recovery. Thank you so much.
Thank you so much, Dr. Lakmal Fonseca, for that comprehensive talk. So moving on, the next speaker is going to be Professor Channa Yahatugoda, who is a professor in parasitology, and he's going to speak to us on filariasis. Over to you, Professor Channa.
Thank you. Hi, everyone. Are our lymphatic filariasis patients, LF patients, have a new hope? I would say yes, and let me justify my answer by going through these few slides. This is an ancient disease, and it has can go up to even Buddha's time. Buddha has sermon of 1 pot-sized scrotum. And it is not an unestimated valuation. We have seen this much of big scrotums due to lymphatic filariasis. Right now what we have is a tiny edema appeared at the dependent part of the body, and we're supposed to evaluate it. When you are trying to evaluate it, if you keep in your mind all the differential diagnoses, including lymphatic filariasis, and this is how you should evaluate. And look at the edema, whether it's accumulated to the dependent part, whether it's progressing or not. And if it is unilateral, it could be lymphatic filariasis. Chances are very much higher. And associated fever. When they have a little bit of cellulitis and with a little bit of fever, you tend to think of acute filarial fever plus could be lymphatic filariasis. And the involvement of the lymph nodes, lymphadenitis and lymphangitis. When they have a little bit of tenderness and the pain over the inguinal region, if it is lower limb, around the axillary region, if it is the upper limb, and they can have pain along the lymphatic trunk. So those are the things that you can evaluate while you are taking the history and while you are doing your examination. And this disease is commonly seen among elder people. In Sri Lanka, we didn't see it among the young group, whereas India, they have a lot of young people with lymphedema, but Sri Lankan picture has not changed because we have started our elimination program in 2002, and we managed to suppress the transmission to 0 level by 2006. And in fact, we reached the elimination of the disease as a public health issue by 2016. And the other thing is females. If you see this lymphedema, unilateral lymphedema with this classical history, you can think of filarial lymphedema because they do have a large pelvis and they tend to get lymphedema when they have filariasis. The differential diagnoses are these. You might think congenital lymphedema and you might think medical causes, and don't forget about medications. Some of the adverse events are the lymphedemas and the surgical causes. And lymphatic filariasis, the main pathophysiology is dilatation of the lymphatics, lymphangiectasia. It caused not only by the parasite itself, of course, the parasite do secrete endosymbionts. The main ingredient is Wolbachia, and it triggers the inflammatory pathways, and the host factors are involved with the dilatation of the lymphatics, which is the important thing which progress the lymphedema. And the human factors are angiopoietin, vascular endothelial growth factors, and metalloproteases, right? So I'll come to that when I'm going to do the management part because it's very important. And then you will order a bunch of labs, and there are a lot of results will come and will help you to differentiate all these differential diagnoses. But some of the labs will help you to diagnose LF. Ultrasound is one of them. And circulating filarial antigen test would be the best, and I'll come to that in a little while. And FAT, or the filarial antibody test, is the commonly used one, which is, I would say, useless. This is one of the animal model after dissecting, have shown lymphangiectasia, dilated lymphatics, and moving worms inside. And can we detect this from outside? Answer is yes. And humans, we don't dissect to diagnose lymphangiectasia. What we do is we use a specific probe, ultrasound probe with a special frequency, 2 to 5 megahertz, and where you will be able to demonstrate the dilatation of the lymphatics and the moving worms. That is diagnostic. If you can do that, you can diagnose lymphatic filariasis on the spot. And circulating filarial antigen test would be the other test, the issue is when they come to you with lymphedema, most of the time they don't have circulatory antigen test, positive test. They don't secrete the antigen to the circulation, and which is very challenging. And what we had was ICT, immunochromatographic test, which has a lot of limitations. You cannot keep it outside the refrigerator. When it's taken out from the refrigerator, you have to use within a few hours, and the shelf life was like 6 months. But we tried to improve it in a different way, and we produced a fluorosis test strip, and I am part of it, and I did field test the same test in Sri Lanka and found which is more sensitive and can be kept in outside the refrigerator in our ambient temperature. 30 degrees possible with this test, and shelf life has gone up to 1 year. So which is very a sensitive test, and WHO has recommended this test for the diagnosis of lymphatic filariasis, and WHO has donated a lot of test kits to our national campaign. Unfortunately, the person who is trying to get this down for the business could not get it down due to certain reasons, and then NMRA has to look after that. That's why this test is not freely available. Not only that, now we have another challenge. MF positives, not all MF positives get positive with the antigen test. There are some MF positives, they are negative for antigen test, which means that they might have a different worm. The worm was Wuchereria, not the Wuchereria brand coffee, the other one, Brugia malai. Now we found Brugia malai in our population. We happened to eliminate Brugia malai in 1960s, but unfortunately we see hepatocyte cases right now. And they are not human Brugia malai, they are zoonotic Brugia malai. And our team went beyond and did the sequencing and found this Brugia malai is not the Brugia malai, even the zoonotic Brugia malai we have seen in Sri Lanka, they are different to that. So they found it closer to Brugia pahangi, and we did the same. And so we think it could be a novel Brugian species. Now we have a challenge to diagnose Brugian filariasis. Right now, antibody tests are available in the world, which is not available in Sri Lanka freely, and the campaign has given some of the tests to confirm these cases. We have to get down those tests to Sri Lanka to diagnose Brugia. The most challenging part is alleviating the suffering of these lymphedema patients. So they do have a lot of issues because of this lymphedema. And they have huge limbs like this, or they might have even a tiny limb affecting their psychology. And so we took a challenge to see that WHO has proposed an essential package of care. And we took challenge to see whether this essential care, the package of care, can alleviate the suffering. And the package includes regular hygiene, clean the limb regularly and keep drying the limb without keeping wet places, and look for entry lesions regularly and keep treating them till they disappear with antifungal and antibiotic treatments, and do regular exercises in the affected and unaffected parts of the limbs, and keep elevated their limbs during day and night, and protect their limbs by using protective wear in and out. By doing that, you can alleviate a lot of sufferings. And we have observed that even the mossy lesions, the tiny warty-like lesions, are disappearing after regular care. And the most interesting thing we have seen in this work, the piece of work, patients, those who have touched daily and had a chance to talk to each other daily, have more improvement in quality of life. Their dermatology life quality index has improved, and the lymph volume has really gone down, and their knowledge on the disease has really gone up, and they had very high benefit scores, plus their entry lesions and adverse acute inflammatory episodes have really, really gone down. And the qualitative aspects also really gone up. And I've told you that the pathophysiology involves angiopoietins, vascular growth factors, vascular endothelial growth factors, and matrix metalloproteinases. And you can suppress these ingredients by, as an adverse event or side effect of doxycycline. Doxycycline is the treatment for Wolbachia. Wolbachia is the one which triggers all these inflammatory reactions. And since they have found that, we used doxycycline in one arm, treatment arm, and we had a placebo arm, and we did a randomized control trial using 200 patients, and this randomized control trial was a multi-country trial, and we found that the patients are really responding to this essential package of care plus doxycycline. So we observed even the grades are improving. And we need a method to evaluate their progression. So we use 3D scan with the AI platform where the limb contour is come to a screen. We will be able to measure the volume, exact volume, and the circumference. And so we have all these facilities in my clinic, and the clinic is open in every working mornings or every working Friday. And further, we try to reduce the edema by using a special garment where you have short stretch compression. And this is, we found that it is not that hard a person can do, and you can appreciate the reduction of edema in these photographs. And there are a lot of other manifestations due to lymphatic fibrosis which we don't see much in our country because the transmission has really gone down. And the management has not been changed even. And these are the new challenges. We do have animal filarial worms can jump into us and cause problems. Here you can see a Dilophilaria repens, juvenile adult, is living inside the anterior chamber of the eye. So in summary, what you have to remember, if you get a case, lymphedema case, clinically evaluate, get a thorough history and examine it and try to find the most important clinical signs and the symptoms to diagnose lymphatic filariasis and have a clinical diagnosis. Because the laboratory diagnosis might not help you to diagnose your cause. And then manage it as a lymphedema. Use the WHO's essential package of care and manage them as lymphedema. Thank you.
Thank you, Professor Channa and Hatuguda for the excellent talk. And moving on, next speaker is Dr. Sunith Karunaratne, consultant cardiologist. He will talk about the infective endocarditis. Over to you, Dr. Sunith Karun.
Good evening, ladies and gentlemen. And I think you must be pretty tired, and all of you being here in a sunny afternoon, so you must be very dedicated. Moving on, there are many things if you want to discuss about endocarditis. So in summary, we'll discuss the antibiotic prophylaxis a little bit and the preventive measures to prevent endocarditis, diagnosis, role of imaging, and empirical antibiotic treatment, indications for surgical intervention, and finally the endocarditis team. Of course, we can't discuss everything about endocarditis in 10 minutes, so we'll focus on a few important areas. So the patients who need prophylaxis there are two groups: patients with high risk of infective endocarditis and patients with intermediate risk of endocarditis. These are the four categories who has the high risk of infective endocarditis. Of course, there is patients with previous history of endocarditis and surgical implanted or transcatheter implanted valves like TAVI, and patients with untreated cyanotic congenital heart disease or treated patients where there are residual shunts or prosthetic material, patients who have ventricular assist devices as destination therapy for patients, especially in heart failure patients. These are the categories of patients with intermediate risk, especially rheumatic heart disease, non-rheumatic degenerative valvular disease, congenital valve abnormalities like bicuspid aortic valve, and important category, cardiovascular implanted electronic devices, ICDs, CRT devices, and pacemakers. Now we have a significant proportion of patients, even increasing population of patients with these devices. So the risk of endocarditis in these categories of patients is expected to rise in the future, and also hypertrophic cardiomyopathy. Prophylaxis is actually indicated only for, definitive indication is only for patients with high risk. Intermediate risk category patients, you can decide whether you need to give a prophylactic therapy or not, depending on other risk factors. These are the portals of entry for patients with for endocarditis, which causes bacteremia, infections of the skin and oral cavity, and intravenous drug users, healthcare related exposure, especially when in your wards patients have intravenous cannulae or central lines. Oral surgery, all dental extractions, periodontal surgery, and oral biopsy, dental procedures like root canal treatment, where it involves the manipulation of the periapical region of the teeth. So all those oral surgery procedures, high risk group need antibiotic prophylaxis. That is a class 1 indication. In other procedures like skin, transfusion, dialysis, bone marrow, endoscopy, those, the indication remains class 2B. Indication is not as strong as for oral procedures. For the cardiovascular interventions, patients undergoing, there are many patients who undergo cardiovascular treatments interventions nowadays. If you are going to implant a prosthetic valve or any type of prosthetic material, or cardiac implantable electronic device such as a pacemaker, they should be given antibiotic prophylaxis prior to the procedure. And patients who are awaiting cardiac surgery should have preoperative screening of nasal carriage for Staph aureus, and if positive, you should treat them with mupirocin and chlorhexidine. But systematic local treatment without screening is not recommended. And if the patients who are waiting for elective surgery, if they have any dental sepsis, those should be eliminated at least 2 weeks prior to the surgery if the time allows. General preventive measures are indicated for all high-risk patients as well as intermediate-risk patients, and actually these measures should be applicable to general population as well. You have to do twice daily tooth cleaning, brushing or flossing, professional dental cleaning and follow-up for the high-risk patients every 6 months. For intermediate risk category, at least yearly. Strict skin hygiene and treatment of skin chronic conditions. If the patient have urticaria, patients has eczema, they have to be treated. If they develop any focus of bacterial infection, they have to be treated promptly. And patients should be advised, high risk and intermediate risk category patients should be advised not to self-medicate with antibiotics. And they should be discouraged of having tattoos and piercings. And when you insert peripheral venous cannula or central cannula, strict adherence to care bundles should be adhered to. So which one is the more genuine smile, you think? Of course, it's known that males always have a genuine smile. But in this patient, if you have a nice set of teeth, it's easy to smile. But if you smile with bad teeth, then it shows your smile is genuine. But this is the kind of patients who is a nightmare when they come to your valvular heart disease clinic, because patients who undergo prosthetic heart valve procedures, patients who have valve replacements, they do not follow the previously agreed upon plan after they are well. So you have to educate them. When you are doing a valve replacement, you are actually replacing a disease with another disease. So the surgery is not the end of the valve disease. You have to adhere to adequate dental hygiene practices. Moving on to the diagnosis is sometimes a diagnostic challenge. Sepsis or fever of unknown origin in the presence of those cardiac or non-cardiac risk factors, and can present as acute, rapidly progressive infection. It can crash and burn, like the flight to London, a subacute or chronic disease with low grade or even no fever and generally unwell, patients coming and saying they are feeling feverish, and then they can present to the subspecialties with a complication. They can present to a neurologist with a stroke, they can present to the rheumatologist with joint problems, they can present to nephrologist with glomerulonephritis. So you have to be mindful, those complications, patients might come initially with a complication of endocarditis. So if you have endocarditis, you have to do blood cultures. If blood cultures are negative, then you have to think about blood culture negative endocarditis, like has a group of organisms, then you have to go for serology and PCR. The imaging is one of the main forms of diagnostic. It is one of the major diagnostic criteria as well. Transthoracic echo is the first line imaging modality in suspected endocarditis. Transesophageal echo in all patients with clinically suspected endocarditis if transthoracic echo is negative or non-diagnostic or inconclusive. If prosthetic material is present, TO is a must. And if initial echo is negative, you have to repeat the echo in 5 to 7 days if the clinical suspicion of endocarditis remains high. And TO is recommended in all patients, even if transthoracic echo is positive, because sometimes you can detect complications which are not seen in transthoracic echo when you do a transesophageal echo. So, two major criteria, blood cultures positive for endocarditis and imaging positive for infective endocarditis. There are 5 groups of minor criteria. This is how you diagnose definite endocarditis, possible endocarditis, and you reject endocarditis. So, all of this is very clear. Then when you think about the microbiological susceptibility, there are certain terms: susceptible at a standard dosing regime, and susceptible at increased exposure, and resistant. Those are 3 classifications for the antimicrobial agents for a certain organism. Now, after there is a study, you can under certain conditions, you can, after first 2 weeks of intravenous inpatient treatment, you can continue in some specific patients with oral therapy or outpatient parenteral antibiotic therapy. But you have to have these specific criteria have to be met. So it says, all in all, about 20% of patients will be able to get oral therapy after the initial 2-week inpatient parenteral treatment of IV antibiotics. Some patients can become complicated, which you might need these to consider transferring them to a heart center with the endocarditis team. If the patient becomes unstable hemodynamically, severe valvular regurgitation, prosthetic valve endocarditis, complications like stroke, extravalvular complications, positive blood cultures despite appropriate antibiotic therapy, and cardiac implantable electronic device related endocarditis, those patients might need transfer to a center with endocarditis team. And there are 3 surgical indications. One is heart failure. If the patient develops intractable heart failure and cardiogenic shock, you have to go for surgery. If the infection is uncontrolled, not responding to appropriate antibiotic therapy, you have to go for surgery again. And if the patient has embolism and there are vegetations more than 10 millimeters, then again you have to go for surgery. This surgery also very high risk surgery. So surgeons are not very keen to do the surgery because these patients might need prolonged ICU care, and there's a risk of getting infected. The new implanted valves can get infected as well. So it's very important to diagnose and treat the infection early. The heart valve center should have these kind of specialists, so you can make the informed decisions at earlier time, and you can come to more accurate diagnosis, and antibiotic treatment can be more uniform for the similar kind of patients, and you can decide on optimal timing of surgery when you have all the specialties available. to decide on optimal timing. Thank you.
Thank you very much, Dr. Suneth Karunaratne. And since it's a rapid fire session, unfortunately, we will not be entertaining any questions, but let me invite all 4 speakers to receive their certificates of participation. Dr. Niranjan Disanayaka, Dr. Lakmal Fonseca, and Professor Channa Hatugoda and Dr. Suneth Karunaratne, please.
Thank you, Dr. Kumari Hami and Dr. Jaivira Bandara for guiding us through the session. So, ladies and gentlemen, we have reached the end of the first day of the Infectious Diseases Conference 2025. This is to remind you that 12 CPD points will be awarded for participating at this conference, and an e-certificate will be sent to your email. I'd like to extend a heartfelt thank you to all our speakers, chairpersons, participants, and organizers for making this event a verified success. We'll be having the second and final day of the conference tomorrow on the 13th of June 2025, packed with erudite discussions, pockets of knowledge at every corner, in addition to an intriguing quiz to look forward to. Do join us tomorrow and get ready to be inspired. So with that, let us wind up the proceedings of Day 1 of Infectious Diseases Conference 2025. Have a good evening, ladies and gentlemen. Thank you.